Yes, Samir, please start.
Hi. So, good evening, everyone here on the MahaIP platform, and we are on the Friends of PICU. Today is our 10th session on the Friends of PICU, and is of the part of the MahaIP program. Today is almost 447th program in last 1 year done by the MahaIP, and thanks to the Dr. Hemant Gangulia sir as a president, and Jaykumar Bhandarkar sir as a convener, and also with us having Secretary Dr. Amol Pawar. And I am here for today's session. This one is on the Friends of PIC along with Jay Kumar Bhandarkar sir as a guide here. So something about the Maha IP program on this channel. This is our 10th session so far in Friends of PICU, and we always called one of the experts in particular field. And so far we have confirmed, we have done so far is a X-ray chest, ABG in the blood, anemia, rheumatology, ENT, cardiology, neurology, endocrinology programs. And today we are with us having Dr. Pankaj Deshpande sir. And this will be our 10th session from the starting. This is a very popular program. It's seen by the people across Maharashtra, India, and across the world sometimes. And also is live on YouTube. So whatever is now visualized here is also visualized on the YouTube channel. So something about the Pankaj Deshpande sir. Pankaj Deshpande sir is a pediatric nephrologist consultant. Hello. Yeah, thank you. So, Jay sir. Hello.
Yeah.
Yeah. So,
आवाज गेला तुमचा.
sir. I'm introducing the Pankaj sir also. Okay.
Yeah.
So, Pankaj sir is a pediatric nephrology consultant at Hinduja Hospital and at Bethany Hospital and in Vashi. And he's a consultant nephrologist in the Southampton General Hospital in UK in 2001 to 2005. For 10 years, he has worked in the various specialties in the various places in UK. That includes Guy's Hospital, BCH, and in the Cardiff Institutes. And he is a national and international speaker. So thanks to we have the Pankaj Deshpande sir today.
Thank you.
For us. Dr. Jay Kumar sir.
Yes, sir. Good evening. I will not speak much. Rather, I will ask Dr. Neha, our editor-in-chief for this Dushti, this Maha-IP, our journal of that souvenir, and she's preparing for that. Neha, your message, please. And later on, Dr. Renu and Dr. Jitendra will speak, and we will kickstart our session of nephrology. Thank you.
Yes.
Neha, madam.
Yes, sir. Thank you so much, sir. Today, yes, this is the 10th episode, and we welcome Dr. Pankaj Deshpande, sir, today to our platform. We would like to hear him. He was my mentor. Mohite sir and Pankaj sir was my mentor, and we would like to hear him again. So I welcome, sir. Over to you, sir.
Okay. Renu, madam, तुमच्या काही blessings द्या.
Yeah, good evening, one and all. It is a feast to listen to Dr. Pankaj Deshpande, sir. He has visited Aurangabad many times. Sir, I am from Aurangabad. And I congratulate Dr. Jay Kumar, sir, and Samir, sir, to have this program. And also our President Gangolia ji and Amol Pawar, our secretary. And Neha, hello to you too. All the best for this program. I think it is an interactive session, sir told. So it will be very interesting. Yeah.
Okay, yes. Jitendra, Dr. Jitendra, are you there?
Yes, he's there.
Photo दिसतोय पेशंट बघत असेल.
Jitendra sir.
Yes, sir. There is a lot of noise around actually. Thank you for keeping Pankaj sir's talk today. Actually, Pankaj sir has changed the vision we approach any nephrology case in our day-to-day practice. He initially scares and then gives pearls of wisdom how we should not miss the common things which we overlook many times. So I'm very eager to relearn from Pankaj sir.
Okay, thank you, Jitendra. Over to Pankaj sir. You can start your dialogues, whatever monologue, dialogue, interactive. Let us have a free flow, somewhat different. Like you can ask the question. Any audience or audience present, you can type in the chat box or open your video or audio. And, please ask, answer it. Let us enjoy this two-way dialogue. I can say more.
Okay. Can I share my screen now?
Yes, sir. Yes, sir.
Yeah,
Please.
yeah.
Thank you, sir.
You can see the screen, no?
Yes, we can hear you also, and we can see the screen. Yes, sir.
Yeah. Okay. So as somebody or Dr. Jitendra said, I usually scare. I don't think that's true. I'm going to start talking about very simple things that happen in our OPD. And I wondered what theme I should select. And the topic that I thought makes more sense, because what we see in OPD is hematuria, because we often hear theory discussions about what to do about hematuria which presents in the OPD. But does it really help us when we are faced with a child having blood in the urine? So let's start with this, because what we are only going to look at is commonly seen issues in hematuria. So we are not talking of intensive care problems that are such. And some of the features that come up are confounding. So we are going to start with cases, because as I believe our patients teach us a lot more than the textbook. So this is the first child, who's a 4-year-old girl who presents with fever. She is well grown on examination. She has a cough. Now she has a urine test done. Don't ask me why the urine test was done, but it was done. Now that is the report that is given there. As you can see, it is yellow. Occult blood is 2+. Protein is trace. RBC is 1 to 2 per high power field, and pus cells 3 to 4. So this is a very simple case. And the first question is, what would you do about this hematuria? And secondly, is it a urine infection? I think everybody gets the second part easily, but it's just to reiterate what we have to do. But the first part, what would you want to do about this hematuria? Anybody?
Whether it is a gross, very persistent.
Okay. Thank you for answering, Jay. So exactly to address this issue, the first point we need to note is that positive occult blood is not sufficient to label as hematuria, because it depends on the pseudoperoxidase reaction of heme. The hemoglobin part, the heme jo hai, that causes this reaction, and tetramethylbenzidine is the reagent which is present in the stick, which is very, very sensitive. And therefore, even if you have 1 or 2 RBCs which are lysed, you will start getting occult blood which is positive. So to define hematuria, you need to have presence of more than 5 RBCs per high power field to call it hematuria. So occult blood positive is not equal to hematuria. That's the first thing we need. Because very often parents come waving this report at you saying occult blood 4+, kya kare bacche ka, because they have gone on Google and read right up to cancer. So you need to allay the anxiety to tell them that this is not hematuria in the first place at all. In adults, this becomes more of an issue because they are worried about prostate. But even in adults, this is not considered as hematuria. It is called as pseudo-hematuria. So RBCs are often seen in infections like URTIs also. The second part, as I said, very often everybody gets it right. But just to reiterate, presence of occult blood, presence of a few RBCs or a bit of protein is not evidence of a urine infection. You need to have symptoms along with appropriate urine tests. So we'll have another talk about urine infections some other time, which allow us to diagnose urine infections. So if you have 20 to 30 pus cells in a child who's having 100 RBCs, that may not necessarily mean a urine infection. So pyuria does not necessarily mean a urine infection. Just keep that in mind. The second child, so now this is a 5-year-old girl who presents with fever for 2 days. There is no focus on examination, and hence she has a urine test done. Now you can all read the report there. It shows a specific gravity of 1030. It's clear in nature. It's trace protein, occult blood 2+, pus cells 3 to 5, and this time there are RBCs 10 to 12 per high power field, and epithelial cells are 1 to 2. Again, a very simple question. Is this hematuria, and what are you going to do about this hematuria? Anyone?
Yeah, this is hematuria.
Okay.
But you need to, again, this patient need to observe another thing, as it is history of fever and female child, where to send the urine culture and confirm urine tract infection. And for hematuria, I think you should better to monitor. If high-grade fever is persistent there, definitely you can start same culture and start maybe drug like cefixime and wait and watch. And you can, if there is a, that you're seeing the proteinuria also, you can send the protein creatinine ratio urine, and whether it is significant or not, you have to take the blood pressure of patient also. He's going for some
No,
nephritis.
I think, Jay, you're covering all the points, but the point that I was trying to make, this is not a urine infection because there is no significant pyuria. That's because we'll again talk about UTI some other time. My question was about hematuria. And again, the point that you need to remember is a single report of more than 5 RBCs per high power field is not considered significant, especially during any infection.
Right.
So if you have respiratory infection, you will get RBCs in the urine. Therefore, significant microscopic hematuria is considered as presence of more than 5 RBCs per high power field on 2 separate occasions. Some definitions will say 3 separate occasions. So it needs to be at least 2 or 3 times done 2 weeks apart for it to be labeled as persistent microscopic hematuria. So if you have fever, a cough, and 10 RBCs, but the next urine 2 weeks later is normal, then it is not considered a significant hematuria to be followed up or to do anything about it. So I think the point I'm trying to make is it's not just occult blood, which is hematuria, and not just RBCs which are raised. It needs to be 2 samples 2 weeks apart in a normal child for it to be called as persistent significant microscopic hematuria. Right. This third child is a 6-year-old boy who gets admitted for fever, is diagnosed as malaria. He has received quinine and the fever is now settling, but now starts developing reddish urine. Now you send a urine test and this is the report that you get. Reddish urine, occult blood 4+, protein 3+, RBCs 1 to 2 per high power field, pus cells 2 to 3, and creatinine 0.9 milligram percent. So the question is, what do you do with this hematuria? What conditions cause this? And what special care needs to be taken in these patients? Anybody?
Samir sir.
I know I'm putting you on spot, but I think these are very common things.
Hemoglobinemia generally happens, not hematuria.
Yeah, this is the patient has maybe the cause is the intravascular hemolysis because patient has malaria. That is first thing.
Yes.
And so special care, I think hydration should be maintained in this patient. And height should be taken and see that creatinine matches the modified GFR. That is very, very important.
No, I think that's the point I was trying to make. So the point is when you have, so the 3 different features in the cases that I have said, if you have reddish, brownish urine with few or no RBCs, it is diagnostic of hemoglobinuria and myoglobinuria. The leading cause of this is infections like malaria or drugs. G6PD deficiency, all these kind of things can lead to hemoglobinuria. And what you need to remember is that hemoglobin elutes out in acidic urine. So what happens is hemoglobin comes out of the urine and it coats the lining of the tubules. And therefore you get acute tubular necrosis. If you don't treat this properly, this child will need dialysis. So to keep me away from your patient, ensure that you not only make the patient pass a lot of urine, but keep the pH above 7. So when you keep the pH above 7, where that is the urine is alkaline, the hemoglobin dissolves in it and therefore comes out and does not coat the lining of the tubules. So what we need to remember from the 3 cases that we have seen up till now is if you have normal urine with occult blood positive, normal looking urine, clear urine with occult blood positive, it is not significant. If you have reddish urine with occult blood positive but RBC is absent, it is hemoglobinuria or myoglobinuria. Whereas if you have red colored urine with plenty of RBCs, it is hematuria. So I think these 3 distinctions need to be made clearly when you see patients in the outpatient department. Right. This next one is a 4.5-year-old boy who's brought with a history of few episodes of red urine for the past 2 days. It is painless and intermittent according to the parents. There's no past history of urine infections or any renal issues. You examine the child and everything is perfectly normal, but there is phimosis which is present. And as you know, my question, so we've also done the tests. So CBC is normal, creatinine is 0.6 milligram percent, ultrasound normal kidneys and bladder, and urine shows reddish urine, occult blood 2+, protein 1+, and RBCs 100 to 150 per high power field. So the question very simple is, this child is advised to undergo circumcision as phimosis is causing hematuria. Yes, no.
Yeah, no phimosis.
No, phimosis
No
doesn't
circumcision.
cause it. Yes. So I think this is a very common occurrence that you see in your OPD, and that's why I put it up here. Phimosis by itself is very, very unlikely to cause hematuria, either gross or microscopic. If at all you troll through literature to find out whether it really caused this, it's with abnormal phimosis, where there are repeated episodes of balanitis and multiple adhesions, which cause tear in the skin, and therefore you get this gross hematuria. Now, what happens is these children undergo circumcision and they continue to have hematuria later because you have missed some glomerular cause of hematuria in these children. So we need to be careful about labeling phimosis as a cause of hematuria in children who present, and circumcision is not to be recommended. Sometimes it is advised even for persistent microscopic hematuria. It is absolutely unindicated. So you should be more worried about a glomerular cause. So this next child is a 4-year-old boy who presents with episodes of red urine for the last 3 to 4 days. There's no other specific complaint, occasional abdominal pain, and is otherwise a completely well child. You examine the child and there's nothing to find on examination. Blood pressure is also normal. There's no rash or edema. You get tests done. A CBC is normal. Creatinine is normal. The urine is yellowish in color. It shows RBCs 50 to 60 and occult blood positive. So what test would you like in this child? You should never miss this. That's why I've specifically put this test. No. Don't think like a nephrologist. Think like a pediatrician.
एक मिनट केस परत सांगता का?
Red urine for the last 3-4 days with occasional abdominal pain, nothing else to find on examination.
Maybe 4 years, na?
Sonography.
Yes, thank you. Never forget an ultrasound scan. Okay, you should never ever forget it, because you will pick up malignancies like Wilms tumor. So to finish off, what conditions can be picked up on an ultrasound scan in children with hematuria? So to just give you a brief list, this is not a textbook list, something that you should remember in OPD. Tumors. So Wilms tumor is the commonest thing in this particular age group. Urolithiasis, so large stones which are descending in the ureter, you will see. Dilated renal system, so posterior urethral valves which have not been picked up, may sometimes have severely dilated ureters and pelvis and may cause hematuria. Similarly, an obstructed system like a pelviureteric junction obstruction, which has been present for a long time with an AP diameter that is really large, can also give rise to hematuria. And rarely you can have nutcracker syndrome. If this child were adolescent, 13 to 15 years of age, you can have nutcracker syndrome, which means that your left renal vein is caught between the IVC and the superior mesenteric vein, and it gets dilated, it ruptures into the pelvis, and therefore you get hematuria. So you can sometimes pick this up on Doppler. So these are the things that you can pick up on an ultrasound scan. There are many other things, but these are the common things you need to remember. Right. So this next child is a 5-year-old girl who is present with history of puffiness of eyes for the last 7 days, more in the morning, and it reduces at night. There is no past history. This child is well grown, the blood pressure is normal, and apart from this puffiness that we talked about, there is nothing to find on examination. You get a urine test done, and this is the report: specific gravity 1015, protein 4+, occult blood is positive, first cells 5 to 6, RBC is 12 to 15 per Hypar field. Now you also get other tests done because you're thinking of nephrotic, and these are the tests that confirm your suspicion of nephrotic syndrome. Albumin is low, cholesterol is high, and the creatinine is normal. So the simple question is, with RBCs in the urine, what would you do about this child?
This patient, though we diagnose a nephrotic syndrome, usually common is minimal chain disease, but you should think, suppose there are RBCs in the urine, significant, or BP, maybe more significant, think of some other, like a rapid onset glomerulonephritis or some other than minimal chain disease, you should suspect. As well as this patient, I think we should think of some other renal dysplasia also.
Correct.
It will be presented.
So this is just to address these questions which come up in the OPD. The commonest diagnosis still remains steroid sensitive nephrotic syndrome. Microscopic hematuria is seen in 10 to 20% of children with steroid sensitive minimal change nephrotic syndrome. So you will not change your approach in this child all whatsoever. You will treat this child like a nephrotic syndrome. As Jay rightly said, there are other conditions which you will think of. So FSGS, MPGN, secondary nephrotic syndrome like in SLE, but this is if they become steroid resistant and if the hematuria persists. So microscopic hematuria per se does not mean you change your approach to nephrotic syndrome. They 10 to 20% of steroid sensitive or minimal change nephrotic syndrome will have microscopic hematuria.
So, sir, how much hematuria should we expect that it can be considered as only minimum change?
No. How much is microscopic hematuria? Can be anything.
Anything, yes.
Clear urine with RBCs more than 5 is microscopic hematuria. Okay. Gross hematuria, if you get, the likelihood that it's going to be something else like this or IgA nephropathy becomes higher. But if you have microscopic hematuria, any number of RBCs, it is possible even in minimal change of steroid sensitive nephrotic syndrome.
Okay, sir.
Okay. Right. So this next girl, so now we start going on to slightly more things that need thinking, though you see it in the OPD on always. So 6-year-old girl who presents with 2 episodes of red colored urine. There is no past history in this girl, and the urine that she's passing, the red colored urine, is painless. She also has had a mild fever and URTI 2 days ago that has settled down. Now you examine this child and there's nothing to find on examination, in no tenderness also. A blood pressure which you do is normal, and you do tests in this girl. So the CBC, as you can see there, is normal hemoglobin, white cell count and platelets. Creatinine is normal, 0.6 mg%. A urine routine which you do in this girl shows negative protein, occult blood 2+, and RBCs 50 to 60 per high power field. And you get an ultrasound because we just said that you shouldn't miss doing an ultrasound in a child who's got any kind of hematuria. And I don't know whether you can see this. Can you see this white spot here?
Yeah.
Yeah. So this is now reported as a small calculus in the upper pole of the kidney, which is 2 to 3 millimeters in size. There is no dilatation or hydronephrosis that is seen in this child on the kidneys. And so my question, these are the children who are going to first present to you very, very commonly. This is the ultrasound report because the parents read it, they get hyper and they are coming to your clinic. And now you're going to have to make a decision. What action would you take for this calculus? And how will you treat the hematuria part of this calculus?
This is URT with hematuria and painless and other BP output, everything is normal. I think we should separate IgA nephropathy in this patient, which can cause gross
calculus. No, that's different. I'm asking about the calculus.
Asymptomatic calculus. Calculus is asymptomatic. There's no pain, other thing. Rather is even doesn't cause any trouble to the patient. I think we should keep aside, watch on that.
Hydration.
Okay. So now you have all advised this to the child and the parents. What do you think the child does? He doesn't listen to any of you. So where does the child land up? So the doctor has given advice, then they go to their neighbors, they go to their friends who tell them stop eating palak, stop eating tomatoes, vegetables and fruits, khau naka. That's what they do. And then they find, where do they land up finally? They land up here. True or not? I mean, I think this is the normal circuit that the patient follows with this kind of report. And hota kai pude. So what happens is they follow this advice for 2 or 3 months. They never get pain, and they repeat an ultrasound because they are always worried about the calculus. And what happens? This is the ultrasound which is done, which now shows no calculus.
Yes, sir.
And then where are they going to follow up? Are they going to come back to you or go there?
Actually,
याच्याहून wonderful treatment कुठे मिळणार आता?
That's it.
Automatic. ते गेलेला आहे ते जो खडा होता तो गेला. What else do they want?
त्याचं पोटात हात ठेवून पेशंट तपासायचा, नंतर सोनोग्राफी मी हात लावल्यावर कॅल्क्युलस गेला म्हणायचं.
So I think what I'm trying to bring out is this is what happens in the community, and this is what we need to address. So where have we made a kind of error in our judgment at the beginning?
Right.
So what have we done? So we need to first remember गावस्करच्या फिल्मचं नाव काहीतरी वेगळं होतं, प्रेमाची सावली, पण आपल्याला जे लक्षात ठेवायचं आहे तो हा खेळ सावल्यांचा असतो. का तर आपली सोनोग्राफी म्हणजे आपण नुसतं सावली बघतोय.
Right.
And so we need to understand the Sauli for us to understand what to tell the patient. Okay. So the first lesson we need to take home is that everything that glitters is not gold. Je kai they report kartat, when they say it is a stone or a calculus on an ultrasound, does not mean it is a calculus always. How do we make that decision? Size matters. बाकीच्या कुठे size matter नाही करू दे. Size matters in ultrasound. So if the calculus which is reported is more than 5 millimeters in size, the specificity of an ultrasound to detect calculus is close to 95-99%. When the size goes below 5 millimeters, the specificity of the ultrasound starts dropping drastically. So you're talking of 60%, 50%, 30%. 2 millimeter calculus, it becomes 30%. So when they report a calculus of 2 to 3 millimeters in size, very often it may not be a calculus at all. And that is why all other treatments work, because there is no treatment required for this kind of a calculus. What we need, so what is that? What is the radiologist seeing, which is what he's reporting as a stone? So remember, the kidney is a very vascular organ. So end on view of the blood vessels looks exactly like a stone. And therefore, any white blob in the kidney gets reported. The radiologist is not wrong because he doesn't know what it is. So he reports it as a calculus. So what other things? You can have pyramids sometimes which are echogenic, which get reported as a calculus. Fungal infections can get reported as a calculus. So how do we overcome this? How do we find out whether it is a calculus or not? So there are two ways. The first one is very difficult. You need to know your anatomy of blood vessels. ते आपल्या पहिल्या MBBS मध्ये शिकल्यानंतर आपल्याला डोक्यात लक्षात राहत नाही. त्यामुळे ते बोलणं सोपं आहे, करणं खूप कठीण आहे. So the easier option that we have is if you take a torch and keep a stone in front of it and put the torch on, you will get a shadow behind the calculus. That is exactly what should happen when you are using the ultrasound scan.
Right.
So when you use the ultrasound scan, and if it is a calculus of significant size, you should get shadowing behind the calculus. So if you don't get shadowing, the likelihood of that being a stone becomes very low.
Sir,
So,
Pankaj sir.
Yeah.
While performing USG, we have to take a torch.
No. I was just giving an example. Torch आपल्यासाठी खडा ठेवला बाहेर किंवा तुम्ही ग्लास ठेवला आणि टॉर्च मारला तर शॅडो येणार.
Yes, exactly.
तसं सोनोग्राफी मध्ये when you put the probe on the tummy, what you're doing is you're generating sound waves which are going through.
Yeah.
So when they hit a stone, there will be shadow behind it because it can't penetrate the stone. Whereas the kidneys, it penetrates, and therefore you can see the image of the kidney.
But that can be very well pursued by radiologists then.
Yeah. So they often report as shadowing seen. Sometimes they report, sometimes they don't. So
Okay.
you need to look at the film to find out shadowing ahe ki nahi. That's easier. Otherwise, remember your anatomy. That's the other option you have. Blood vessel कुठे आहेत ते सगळं शोधून ठेवा म्हणजे कळेल. So if you want to make lots of money, follow what the child did and get an ultrasound done later on. Okay, so just to give you an example, can you see this? It's not a very good image, but this is the arrow that has been pointed here, and this is a 3 millimeter, not this child, some other child reported as having a calculus. Now this same child, just a week later, ultrasound at a different place, you can't see any stone. And don't just take my word for it. I hadn't seen this child at all. They came to me at the end, but somebody had also done an IVP in this child. The IVP also didn't show a stone. So there was no stone whatsoever. There was no stone which passed or whatever. There was no stone at all. It was just a pickup on an ultrasound, which was probably a blood vessel, and therefore it was reported as a stone. So any size less than 5 millimeters, be careful of labeling it as a stone because it may not be a stone in the first place at all. Okay. Then secondly, as Dr. Jay rightly pointed out, correlate the symptoms of the child to the results of the tests that you are getting. So if you have a calculus which is 5 millimeters, 2 millimeters, 3 millimeters, which is sitting in the calyx, it is very, very, very unlikely to cause hematuria. There is no business for it to cause hematuria. So hematuria occurs when the stone is descending down the ureter and is hitting the walls of the ureter. So it needs to be a significant size and hit the ureteric wall. So you will get pain and you will get hematuria at that time. A stone sitting in the pelvis can cause hematuria if it is very large and is abutting the pelvis. So there may or may not be severe colicky pain. You may get only a dull pain, but that's where you will get hematuria. So a stone sitting in the calyx, which is 3 millimeters, is very, very unlikely to cause hematuria. And therefore, whatever you're seeing on the ultrasound is not the cause of hematuria in this child. So you need to investigate the hematuria more to find out whether there is any other cause like a glomerular cause. So that's the important thing that you need to remember. So tiny calculi in the kidneys do not cause gross hematuria unless they are descending down the ureter, which is painful. So we need to worry about glomerular causes in these children with hematuria. If hypercalciuria is present in 5% of the normal population. So you can have a child who's got an underlying hypercalciuria, but has also developed a glomerular disease. The second point, as I said, reported calculi less than 3 to 5 millimeters may not be calculi at all. So be careful about diagnosing calculi. Right. So now we move on to the next child, who's 10-year-old boy who presents with severe left-sided abdominal pain, which is colicky in nature. He also has vomiting along with the colicky pain, and there's a previous history of calculi in this child, renal calculi. So you examine, and this child is perfectly well on examination. Blood pressure is normal, and systemic examination is nothing significant to find. Now, this is the ultrasound which is done. Right. If you see the arrow here, this is the first one, which is in the calyx. Now, this is 5 millimeters. And to tell you the point that I was making, this is a calculus in the ureter. Can you see this black line behind it? This black line is the shadowing that I'm talking about. So if you see this shadowing, of course, the fact that it is in the ureter itself tells you it is a calculus. But even if it weren't, this shadowing tells you that this is a calculus, which needs to be taken significantly. So there is a calyceal stone in the right kidney, which is 5 millimeters, and a lower ureteric stone in the left ureter, which is 5 millimeters in size. So the next question obviously is what should be done in this child? Anybody quickly? Otherwise, I'll go ahead anyway. पालक बिलक बंद करायचं की नाही करायचं? तेच तर करतात लोक.
Maintain the hydration and can go for
Correct.
this calcium protein
right.
ratio.
Okay, so the action in case of a child who's got calculus depends on the location, the size, and the type of the stone. So in general terms, so specific is a different area altogether. So in general terms, renal calculi which are less than 5 to 6 millimeters in size can be given a trial of conservative management. Why? Because the ureteric size is 5 to 6 millimeters. So if the stone is bigger than that, then the likelihood of the stone descending becomes low. But it's not 100%. The reason being you don't know which diameter the radiologist is measuring. Is it the longitudinal diameter or the cross diameter? So sometimes a calculus which is slightly bigger in size, we may still give a trial to see whether it will descend. Because if it is longitudinal diameter and the cross diameter is 3 millimeters, it will descend. So 5 to 6 millimeters is something you should remember. Now, one of the things which you need to address and tell the patients and remember yourself is there is no medication in the world which dissolves the stone. That's all for making money. So unless there are specific stones, for example, uric acid stones, the treatment is alkalinizing the urine like we did in hemoglobin urea. then the stone dissolves. All other stones will not dissolve. They will either sit there and increase in size, or they will descend and come out through the urethra. A stone which sits up in the kidney will never remain the same size over a period of years, because once a nidus is formed, you keep on accumulating calcium and stone forming substances on it. So the calculus will keep on growing in size. So what do? This boy has a calculus which is 5 millimeters in size. So you ensure good intake of fluids. What do we mean by good intake? Very often we say, पाणी जास्त प्या. पाणी जास्त प्या म्हणजे 2 ग्लास ते 3 ग्लास पितो तो पुढे काय? That is no meaning. So it needs to be double the maintenance. So 20 वर्षाचा मुलगा असेल, 1.5 liters is what he requires. Tell him to drink 3 liters, then he will go and drink 2 liters. Otherwise he won't. Okay. What the principle behind conservative management is, you increase the fluid intake so that the fluid puts pressure on the stone in the ureter and pushes it down. At the same time, you have to provide pain relief and an anti-inflammatory agent, because when the stone hits the ureter wall, there is severe inflammation and it actually goes into spasm to try and stop the pain. So you have to relax that. So anti-ceratopeptidase medications are required for that. And it has been shown very conclusively that medications like either tamsulosin, which is an alpha blocker, or your amlodipine, which is a calcium channel blocker for blood pressure, works extremely well in ureteric stones. If you give it for a period of 2 weeks, it dilates the ureter sufficiently so that the stone passes out. So there is a 50 to 60% success rate when you use these patients along with the other measures that you do, so that the stone can come out. So how long do you give this conservative management for? And before that, when would you not do, or when would you stop your conservative management? So maximum you give about 3 to 4 weeks to see whether the stone comes out. You should never do it in a staghorn calculus. A staghorn calculus is where the calculus has gone into the calysis. There is no way the stone can come down. Radiolucent stones, you should be very careful, because the size of the stone may not be apparent on your x-rays. And in the 3-week period which you are waiting for the stone to descend, if the child gets unabating pain that is persistent for days together, you clearly cannot continue. Something has to be done about the stone. If there is continuous gross hematuria which lasts for more than a week, you need to do something about the stone. Or if the child gets recurrent urine infections, something needs to be done about the stone. So the other part we won't go into detail. So if they're bigger in size or large stone load, you do something. And what are the things that are done? I'm not going to go into that.
Sir, any role of Buscopan?
So pain relief, you can use whatever you want. Buscopan will not affect the stone, but tamsulosin and amlodipine definitely dilate the urine. Okay, so once you have done this, the child comes back 4 weeks later, ultrasound shows normal kidneys with no stones. Are you happy?
Yeah.
Yes. Anything
Stone
else
may
you
be
want to
behind.
do?
We don't know.
Sorry?
The stone not seen doesn't mean that it is not there.
No. What that ureteric stone has to be seen. Ureteric stone gone away means it's not there. You're worried about the ureteric one. This, okay, the renal one will come out later. Okay, so just to go over what else needs to be done. So this is a 7-year-old girl who is seen for the history of being recurrently ill. Parat sardi khokla hoto. But she also had episodes of hematuria. So what happened is, this child was examined when she first presented at that time. Her weight was 11 kg, height wasn't taken, blood pressure 100 over 60 millimeters of mercury. There was no abdominal tenderness on examination. And these were the tests which were done. Anything strikes you, we'll come back to this slide later. So hemoglobin 11, white cell count 7,200, platelets 5.2, sodium 132, potassium 3, chloride 105, RBS was 60, urea 20, creat 0.9, and SGOT, SGPT 30 and 20. Now, ultrasound was done, which showed a very large calculus in the upper calyx of the right kidney, which was 1.2 centimeters in size. She also had an IVP, which confirmed the stone size, and she underwent surgery. And she was well after surgery and discharged. So just to show you, this is the stone that they are talking about, which is a pretty big one, and the same stone seen here on an IV. So what do you think happened to this child?
I think patient should monitor the modified GFR, whether monitor for this kidney function test later also, whether missing some displays or other thing.
Okay, so just as I said, even in that previous child and this child, what else you need to do? You need to remember that pediatric stone disease is supposed to be 1% of adult stone disease. So adults get stones far more commonly than children. But in India, the incidence of stones is pretty high for whatever reasons. We are a tropical country, the water and all that. The most important thing that we all need to remember is more than 75% of urinary calculi in children have a metabolic disorder that causes the stone. So if you do not treat the underlying cause, this child comes back to you needing surgery again 1 year, 2 years later. So treating the stone and waiting for the stone to come out is not the end of your treatment. You need to find out why the stone occurred in the first place. So this same girl, just to give you an update, 3 years later, she came back. Now remember, she's 10 years old. She was 7 years, 10 years, 13 kg, height 102, grossly retarded, creatinine 0.3, calcium 9.7, phosphorus 3.2, alkaline phosphatase 833, blood gas 7.2 pH and a bicarb of 14. And the first slide which I put up had shown a potassium of 3 and a chloride of 105. So hypokalemia, hyperchloremia, metabolic acidosis. This child has type 1 RTA, distal renal tubular acidosis, which is what causes hypercalciuria and stones. Now, if you don't pick this up, not only will she present back to you with another stone, but what treatment have you offered her? We haven't treated anything. We haven't treated the cause of the stone in the first place. So within 6 months, her height shot up, her weight shot up once she was on the appropriate treatment. So what you need to remember is the primary investigation should focus on the presence of a calculus and location. The aim should be to identify the underlying cause. Therefore, metabolic workup is a must. And the best metabolic workup is stone analysis. So if you can catch the stone, send it off for analysis so that you can find out what kind of stone it is. And how will you manage that? So basically you have to tell the child की घरी असताना सुसू करतो तेव्हा गाळणीतून करायचं. हे परत चहासाठी नाही वापरायचं, पण गाळणीतून करायचं. टॉयलेट मध्ये जातो तेव्हा, म्हणजे मग त्याच्यात खडा आला की आपल्याला पिकअप करता येईल. So otherwise there is no way of picking up the stone.
Right.
Correct? Yes, now these are the tests that you would basically do. I think it's given in all books, but just to reiterate, CBC electrolytes, calcium, phosphorus, alkaline phosphatase, a creatinine, magnesium, uric acid, and a blood gas. And urine, a urine routine culture only if there are symptoms, a urine calcium, creatinine, protein creatinine, citrate in the urine, and a 24-hour urine oxalate and calcium. Just 1 minute I will spend. This is something that most of us do not understand. Our urine is super saturated with all the elements. So you have stone promoting and stone inhibiting substances. Calcium and oxalate are stone promoting substances. Citrate and magnesium are stone inhibiting substances. So when this balance gets disturbed, you form a stone. So normally the solubility index, so calcium oxalate ratio is less than citrate and magnesium. So when this changes and your index crosses 1, you form a nidus. Once you form a nidus, the calcium keeps depositing on top of it, and therefore your stone formation continues uninhibited. So remember, stone inhibiting substances are citrate, magnesium, and fluids which disperse calcium away from each other. So these are the metabolic causes that we just talked about. You can have hypercalciuria, which may be primary or secondary to conditions like RTA, low citrate in the urine, high oxalate in the urine. Once you understand the supersaturation model, you know what metabolic disorders are going to be present. And you need to pick these up and treat them so that the child doesn't come back to you with a stone. Just to clear a few concepts, because the patients tend to ask you this: fluids, as I just said, double the maintenance. Restriction: would you stop milk if this child were to have a calcium oxalate stone?
No.
विचारतात
No.
दूध द्यायचं का नाही द्यायचं? Yeah, so the point to remember is calcium in the normal diet should never be restricted. Restrict calcium supplements and vitamin D. The reason why you don't stop the calcium in the normal diet is your normal diet contains oxalate and calcium. So what do you think happens to the oxalate in the diet? It binds to the calcium in the diet so that you form calcium oxalate and it passes out through the gut. If you stop calcium altogether, what will happen to the oxalate that is present in the diet? It gets absorbed and then comes out in the urine. So you will actually promote stones if you stop calcium altogether. So you should stop calcium supplements, but not normal calcium in the diet. Okay. So palak, tomato, seed bearing fruits and vegetables, त्याला काय अर्थ नसतो unless you show that the 24-hour urine oxalate is high. So absorptive hyperoxaluria is the only one which needs this kind of restrictions. IVP, please do not go around doing IVPs because they fry your gonads. That's all they do. So unless there is a very specific indication, IVPs are not indicated. And calcium oxalate crystals often seen in the urine only indicate a poor fluid intake in the child. That does not indicate hypercalciuria. Right. We'll move on to the final few cases. So this is a 12-year-old boy who has a history of cough for a couple of days. No significant past history. And this is a very recent case, just not even sent home a few days ago, who's well grown, and he felt a bit breathless with the cough. So what happened was this child got admitted to a local hospital. He was given IV fluids and antibiotics. These were the tests that were done. These were the only tests which were done. CBC hemoglobin of 12, white cell count 15,000, platelets 2.1 lakh. An X-ray chest was done, which was reported as mild streaking, nothing major there. He was discharged after 24 hours because they thought he was better. So when he went home, he developed a severe headache a few hours later. So despite paracetamol and any other painkillers that were given to him, the headache did not settle at all. And then he finally developed 3 generalized tonic-clonic convulsions. Now he was admitted to a different hospital, a bigger hospital, where he was given IV fluids, IV antibiotics, ceftriaxone, I don't remember the antibiotic given, and investigations were sent. So what did the tests show? The tests, these are the tests: hemoglobin 12, white cell count 16,200, platelets 1.8, SGPT 22, creatinine 0.6. Blood pressure check for the first time here is 100 millimeters of mercury, which wasn't checked in the first admission. A urine test which was done showed clear urine, 2+ protein and 60 to 70 RBCs. What do you think this child has?
Nephritis.
Post-infectious nephritis. Okay, so this was the MRI which was done, which showed changes of press. So he also had a C3 which was done, which was low, and a C4 and dsDNA were normal. So this is likely post-infectious nephritis with press. And the cornerstone of diagnosis is low C3 that returns to normal in 8 to 12 weeks time. The reason I am putting this case up here specifically is IV fluids is not the birthright of every patient who gets admitted, and it can actually be very dangerous. You can argue that this child probably wouldn't have landed up in what he did if he hadn't received IV fluids in the first place. The pathology of post-infectious nephritis is a decrease in your renal function and volume overload. So what you need to do is get rid of the excess fluid, not give fluid to the child. If you give fluid to the child who's already got volume overload, you're either going to cause what happened in this child, worsen the hypertension, or they sometimes present with congestive heart failure because you have overloaded the system. And we have had children who needed ventilation for this. Now, this is a very simple condition and should be managed without any problems. So I think IV fluids is not required in every child. Post-infectious nephritis definitely not required, even nephrotic syndrome, because the first order that we write for a child who gets admitted to the ward is IV fluids. So in a child who's got nephrotic syndrome, when you're giving IV fluids, all you're doing is pushing the fluid into the third spaces and worsening the edema because it's not going to stay in the vascular compartment. So unless there is hypovolemia, there is no point in giving IV fluids to any child. So nephritis, please remember, you should never give IV fluids. Nephritis can present with no specific features pointing to the kidney. So there may be no gross hematuria, there may be no cola colored urine. So keep it in mind when a child presents to you with convulsions or cardiac failure. Microscopic hematuria. This child had microscopic hematuria. Microscopic hematuria has been shown to be associated with more severe hypertension in post-infectious nephritis as compared to those who have gross hematuria. It's just an observation. And the other important aspect that everyone needs to remember is Nelson is very, very outdated. Post-infectious nephritis does not need a 2-week gap between the infection and the occurrence of post-infectious nephritis. This child developed it within 2 days of the infection. So you can get it within a few days of the infection or sometimes even when the infection is going on. So that gap is not necessary. So to finish off this same kind of case, this is an 11-year-old girl who had history of fever for 3 to 5 days before presentation. She took local symptomatic treatment and now she's developing puffiness of the face and the feet. Like you examine the child, she's well grown. There's no past history. She has red colored urine. So this girl has history of discolored urine and there's puffiness of the face, eyes and feet. The blood pressure is raised. So for all of you know about the 95th centile and the charts, but for your sake in the OPD, 100 plus 2 times age of the systolic BP is the 95th centile for any child. So just remember that formula. So this child is hypertensive. She gets admitted. She has investigations done which show a urine routine showing reddish urine, 4 plus protein, 4 plus blood, 150 to 200 RBCs and 15 to 20 pus cells. The other tests, CBC is normal, creatinine is 1.8 and then 2 milligrams 2 days later. Electrolytes, potassium 5.1, sodium 142 and calcium 9.2. So this child undergoes a sonography. As we said, everybody needs to have one, which shows increased echogenicity. And just like the other child, this child has a low C3. So you agree that this is post-infectious nephritis?
Yes.
Yes. So now this child, as we discussed in the first case, you don't give IV fluid, you treat with diuretics. So this child is given diuretics. Now, remember in post-infectious nephritis, there are 2 peaks. The first is volume overload and second is renal hypertension. So diuretics initially and then antihypertensive medications because it wasn't getting controlled. This child is given ifedipine and Cardase. So what happens is 2 days later, the edema is reduced. The creatinine has come down to 1.5 and then 1.2. Blood pressure is getting better, but is still on the higher side. And the child continues to have red colored urine. So both the patient and the doctor are happy.
No.
So after 2 more days, now the creatinine starts rising again. So remember, it came down to 1.5. Then it became 1.8. Then it became 2.4. And in 2 days later, 3.24. Urine continued to look red, though the output remained good. So you repeat the investigations. You get a urine routine done, which shows reddish urine, 4 plus blood, 4 plus protein, 100 to 120 RBCs and 10 to 15%. Exactly the same picture as it was in the beginning. You do a protein creatinine ratio, which is very, very high. So the action that was taken in this child is the renal function is worsening with heavy proteinuria and therefore a kidney biopsy was planned. My question is, do you agree with this and what treatment would you give? Complicated वाटते पण एकदम सोपं आहे.
This patient actually treated the proteinuria. Maybe you can try this AC inhibitors and
Okay.
monitor.
Anybody else has any different answer? No? Right. I'll go ahead because anyway, we're coming close to our time. So iatrogenic problems, we create problems and then try to solve them.
Okay.
What medications was this child given for hypertension? Nifedipine and cardase. What is cardase? It is an ACE inhibitor. So when you give ACE inhibitors in post-infectious nephritis, you are creating problems. So what ACE inhibitors do is they dilate the efferent arteriole. So I don't know whether you can see me, but if you have got an afferent arteriole which is coming, then there is a glomerulus and then you have the efferent arteriole. Now the reason blood goes into the glomerulus is because there is a tone of the efferent arteriole. So there is resistance and therefore blood flows into the glomerulus. Now ACE inhibitors dilate the efferent arteriole. So what happens is blood shunts from the afferent to the efferent arteriole without going into the glomerulus. So every time you use an ACE inhibitor, you drop your GFR. So in a child who's got post-infectious nephritis, the pathology is a reduced GFR. Now, if you add ACE inhibitor to the child, it is obviously going to decrease the GFR even further. And therefore, the creatinine is rising in this girl. So the message is please never use ACE inhibitors for hypertension in post-infectious nephritis unless you have no other options. So there is 1 to 2% of post-infectious nephritis which present with severe renal failure, needing dialysis and severe hypertension. In those cases, even after using 4 agents, the BP sometimes never gets controlled. That is where you may have to use ACE inhibitors. But for the standard post-infectious nephritis that you're going to see in your OPD and admissions, never use ACE inhibitor because you will not know what is causing the rise of creatinine. So what about the heavy proteinuria? Is it nephritic onset, nephrotic onset? No. The other thing to remember is do not do a urine protein creatinine ratio when there is gross hematuria or the urine is red for sampling, because all that you are doing is picking up the protein in the blood. Therefore, you get a falsely high urine protein creatinine ratio. So once the urine is clear, then you check the protein creat ratio. Having said that, even in clear urine, you can get proteinuria even in post-infectious nephritis, which can last for 4 to 6 weeks. And as we said in the first case, post-infectious nephritis can occur within a few days of infections and not always after a 2-week interval. So we need to remember simple basic things for post-infectious nephritis because that is the commonest thing seen in a pediatric OPD. What happened to this girl once the cardase was stopped? In the next 48 hours, creatinine reduced, and in next 4 weeks, everything else became normal. There was no proteinuria, creatinine settled, and 2 months later, this child C3 also became normal. So she had post-infectious nephritis, which was complicated by the use of a medication needing consideration of a biopsy, which I didn't do for this child because she never needed. So don't use ACE inhibitors. And remember to do a protein creatinine ratio when the urine is clear. And the last point here is can you have a completely normal urine routine in post-infectious nephritis? You can. So ideally, you are supposed to have gross hematuria or microscopic hematuria. But sometimes you may see a urine routine which is showing absolutely normal picture. The reason being, if there are 5 to 10 RBCs that are present per high power field, the sample is collected in the morning at 10 a.m. It goes down to the lab. Somebody examines it at 3 o'clock in the afternoon. The few RBCs that are there get lyse, and therefore the urine looks completely normal. So that's what you need to remember for post-infectious nephritis. And just to finish off, remember post-nephritis with low C3, it's not only post-infectious nephritis. There are many other causes also. And none of them have a good prognosis. And if you get a C3 which is normal and the child has a nephritis picture, don't say the lab is faulty. There is an illness which can present with a normal C3 also. So all of these don't have a good prognosis except for acute post-infectious nephritis. So to finish, interpret hematuria appropriately. You monitor the patients with persistent microscopic hematuria. Biopsy is required if you have associated proteinuria, and ACE inhibitors are not the first choice in post-infectious nephritis. Thank you. I think that's enough.
Thank you, Pankaj, sir. Actually, it was not a pulse. बरेच ornaments तुम्ही त्या पल्सचे तयार केलेत, मुकुट म्हणा, हार म्हणा, bracelet, whatever. I think you are touched from a simple microscopic hematuria to the renal failure. This is now, I think, actually it was interactive. This forum is open. Almost 70 people are joined today. Thanks for joining in large number.
YouTube is also there.
Ask the question. It's an open forum, no issue. Yes, Samir.
How to differentiate hematuria? That's the best important thing what I learned today. That what you feel is hematuria is not hematuria, and what is not hematuria you feel is hematuria. Thanks, Pankaj sir, for that.
Thank you.
So very nice cases. How much time you have taken this? Like cases are like so unique, and has covered all the different ways, topics, thinking also. Like even that RTA case also, I thought might be the sugar was 60 mentioned there. I was just thinking something related to hypoglycemia or something like, but then definitely small clues were there. Like potassium was 3, chloride was high, something is wrong. So you have to keep in mind that see all the investigations in the one and try to correlate, combine together and find out the what's exactly come there.
Thank you.
Thanks for that, sir.
Thank you. Any questions? कुठलेच प्रश्न नसतील तर त्याला there are usually two reasons why it happens.
So questions are there, but I really want. I heard your one of the sessions last like 3 months before or something like maybe how to collect urine for sampling and for blood for urine culture.
I think that's a
very
different
common
topic.
question, and it's obviously I know it takes another 10-15 minutes, but I do want you should tell the audience here and those who will watching it later on how to take the sample very specifically for routine as well as for the culture, because I remember that you specifically mentioned and you always speak about this part. Today you skip that part.
I think no, but for urine, for hematuria, it doesn't matter. We are talking in terms of urine infection. So when you collect urine for a urine infection, that becomes important. But I'll come back because I need to talk about urine infections completely separately, because that is the same sequence of cases as like this, because that's where we often tend to make errors. And each point is important when you collect urine.
Very true, sir. Very true.
Yeah.
Pankaj says a lot of and the chat box comments, especially from Suhas Prabhu sir. Great talk, Pankaj, as usual, and Rajiv Dhamangar, senior most pediatrician from Alibag, and many others. They are all appreciated about today's session, and I thank you for that. And still, we have the 10 minutes time. Anybody can ask the question. There is any role of steroid in renal calculi as an anti-inflammatory? Somebody asked. Surikant Khop.
No, we don't use steroids. We use ceratopeptidase enzyme inhibitors so that the inflammation settles.
Whether there's, I think, resistant pain cases can you still, because one of my friend pediatrician in the Saudi, he had that small stone in this pelvis and pain was not responding, and that adult urologist advised him steroid deke dekho, like that.
No, we don't use steroids. We don't. I mean, there must have been some other reasons for the steroid being used. It wouldn't be only that.
So for all the stones, do we send it for investigation? Like what exactly it is, structure made up of?
Yes, if you can collect it. The problem is you will not collect it, no. So unless you ask them to collect it, how will you send it off for testing? So only the operated ones, 100% have to be sent. Sometimes the surgeons forget. So unless you analyze the stone, you will not find out what metabolic disorder is causing it.
Then Pankaj, I have one question. When you said in the suppose the hypercalciuria, you can in the calcium and protein ratio into the urine. Whether other metabolic disorder, you can go for some urine test and can we diagnose, right? Hypercalciuria, okay. Other things like auxiliary other things.
So that's what I said. All of them are based on urine tests. So hyperoxaluria, hypositrate urea, hypercalciuria, you can have low magnesium in the serum and high magnesium in the urine.
Okay.
So these are all picked up on urine tests. So you need to collect a 24-hour urine sample. So very often you find that the child is small, so you cannot collect a 24-hour urine sample. So just to touch upon that, a urine protein creatinine ratio has a very good correlation to a 24-hour urine protein.
Right.
But a urine calcium creatinine ratio does not have an extremely good correlation. So you need to do a calcium creatinine ratio 3 or 4 times to pick up hypercalciuria. And sometimes what happens is, if you ask in the family, you will find that the father or the mother also has stones. So instead of asking a 24-hour urine in the child, you just ask the father or the mother to do it, because I can guarantee you none of the surgeons would have looked at it.
Another thing, lot of medications are in other pathies like Ayurveda and homeopathies, other, whether they're really effective or not. I think they might have doing huge sale in the India. I don't know what the out of India.
But that's what I said, that they are treating where treatment is not required.
Okay.
So they are treating stones which are not stones. So the actual stones which are there are never treated by them. So they always come back.
Any food habits, particularly like a spinach or like taking tomato, chocolate, because people are actually feel they can aggravate or they are the reason for having stones.
I said it in my talk. So if you have hyperoxaluria is of 2 types. One is enzymatic defect in the right from birth. So type 1, type 2 hyperoxaluria, or you can have absorptive hyperoxaluria, which means your gut absorbs more oxalate from the diet. So only if you prove that it is absorptive hyperoxaluria will these need to be restricted. Otherwise, there is no point in restricting that, because that is not the pathology.
Dr. Pankaj, one question. If a newborn passes red color urine, the diaper gets stained, and these are because of you. What is the reason and what should be done?
No, I think your question is slightly wrong. Sometimes you see stains in the diaper which are pink. These are urate crystals.
Yes.
It is not hematuria at all.
Okay.
So then nothing needs to be done. It is common in most neonates and you don't need to address it. These are urate crystals. So to prove hematuria, you need to get a urine routine, as I said, more than 5 or 10 RBCs, unless that is present, or you have gross hematuria with plenty of RBCs. And hematuria in neonates, a separate topic altogether. You will have different causes. So renal vein thrombosis, posterior urethral valves are more likely to present in that age.
Why does it come but urate pink?
That's normal.
So why does it?
That's normal in the diet. These are urate crystals that we also often have. But because our urine quantity is large, you don't see it.
What about the phosphate stones?
Yeah, sorry.
What about phosphate stones in pediatrics?
So phosphate stones are usually secondary to infection. That is the Stagon calculus which we talked about. So you get repeated infections, and that's when you tend to get those stones. Most stones are calcium oxalate.
Pankaj, lot of food substances or even natural foods like even beetroot also can cause, even other many medications have the coloring agents, even Chinese food, other thing. They also give a red color to urine. I have seen a lot of patients of like that.
Correct. So that's what I said. First, you need to define hematuria. So just because the patient says red urine doesn't mean the child has hematuria. So unless your urine routine shows the presence of RBCs, you cannot call it hematuria.
Right. So it is quite common, but
yes, very common.
Very common.
Yes.
Yeah. Thank you very much for this. I can think very
You're welcome.
Excellent talk. Because at the end of year and end of our responsibility for a subspecialty, we are going. All friends, please remember. Next December, we are planning some big subspecialty chapter, small CME, maybe with MMC point. And please, everybody attend one special quiz we are doing on the 12th. That is on tomorrow only, 9 p.m. And it is same on Zoom link and MyIP. There's a quiz on the adolescent issues. So yeah, these issues are also very important. Other than yes, nephrology is important, but these issues are also important. So thank you, Dr. Pankaj sir, for
welcome.
Excellent talk. But I think we covered more of a hemature and proteinuria. The urine tract discussion I think suppose myself and Dr. Samis get the again responsibility to continue the subject next year. Definitely we'll come back to you and ask again to touch other more important issues of nephrology. Thank you very much. So thank you, Dr. Samir, for moderating session. Thank you, MyIP. Thank you all audience attending in large number, as well as Pallavi Dharmadhikari. She is our digital wizard or digital support for the all IIP I can think activities. And thank you to Dr. Hema, our president, Amal secretary, doing wonderful job all over year for the not the specialty, many other things. So friends, thank you all of you, and please join these sessions live, and please do join observe this session or listen this all sessions on the YouTube also. So over to Samir for conclusion, and good night everybody. Thank you.
So already spoken by Jay sir about today's session, and once again thanks to Pankaj Deshpande sir for his excellent examples given. That was really nice, and I still feel that I need to watch it again and frequently whenever gets time. So that should be update your knowledge, our knowledge on this part. Because most likely what happens after a few days we'll miss or we forgot the things. So certain landmarks, paper PPTs, we should actually keep collection with us. And that's why we have used YouTube. So anybody wants, somebody has mentioned in this talk, can I get PPT? So my advice for them will be just go on the YouTube, subscribe on MahaIP. And on MahaIP, we have 448 sessions in last 1 year. It's a huge number, and it's a responsibility and credit given to everyone who is watching this one, encouraging the team of MahaIP. So we will try next time to have with us, now only one part is remaining subspecialty, that is a liver and related to liver. And let's try, Jaykumar sir has very big plan in his mind. And if we can able to get for 4-5 hour sessions, so that we can also have some YouTube sessions or on the live sessions, and we'll try to accommodate more people. And we'll also try to have something MahaIP channel will get some credit points, credit hours from the Maharashtra MMC. So please join on the MyIP to watch the things later on. Thanks to everyone who is watching here till last.
Thank you.
Okay, thank you. Good night.
We can stop the session.